You see what I'm saying? So look at something and say, that's that, even if you don't know the real answer to this question. Can you look at it from saying, this would be that, and therefore that's not the right answer? And maybe I'm third years, are you with me? Am I making sense with what I'm trying to say here? Thank you. Okay. All right. Number 5. Okay, this is knowing the physical exam of a mother with fetal alcohol syndrome. Again, you either know it or you don't, you know. And so the answer is the long philtrum and the thin upper lip. Okay. Now, number 6 is one that many of you miss. So we will spend a little time here, okay? Because like I said, Dr. Carney sent me the ones that y'all missed typically a lot of. And those first 5, none of those questions were on the list. So if you miss those, then you really need to say, you know, I shouldn't have missed those just based on my peer group. But in this one, this is tough. Now let's look at this. And in my mind, you should have gotten it down to 2 answers, okay? To be honest with you. But let's, before we get that far, let's just break down this question. Number 1, 2-day-old. Number 2, male. Number 3, Asian. Now, of those, I would argue that if I were looking at this with whatever's to come, I wouldn't jump up and down about a 2-day-old. I wouldn't jump up and down a male, but I would ask myself, why are they saying it's Asian? You see, a test taker will do that. They'll say, I can't do much with male and 2-day because this is a neonatal test. But why are they saying this is Asian? So if you could get down to the 2 answers, that participle might push you to guessing because you're going intuitively, why did they say it was Asian? See? I mean, does that make sense? Well, but it may not have helped you. I mean, maybe it doesn't even impact on the answers, but let's see. So let's go on. Why did they have to say that maternal lactation consists primarily of colostrum? Why would they have said that? What's the point? I mean, y'all know breastfeeding, you know it, and yet they said it. So you should ask yourself, why did they have to say that? I mean, that seems like ridiculous that it would be said in a question, right? It's intuitively that you know that, but they said it. Why did they say it? Okay? Okay, and then it goes on. He's had meconium, which is great. He's lost some weight, which you know, and then of course, here's the billing. Now, I know you don't have a nomogram in front of you, but you know a 14 in a 2-day-old is clearly a problem, not a finding, right? Okay, so we have a problem. And they tell you it's indirect. So, and they tell you the hematocrit is 54. Now, what do you think? 54. It's okay, right? But it's not 60, which it easily could be, or 58. I would agree that probably to help you out a little bit, I would have preferred the hematocrit maybe be 50, just to help you a little bit, maybe push you a little bit. And we'll walk through this in just a minute. But in fairness, it's certainly not high. The baby is not polycythemic. Would you agree? You know, newborn 2-day-old, certainly not polycythemic. All right, now, then here comes the question. Most likely. So you go through it. Well, alpha-1 antitrypsin is a conjugated. If you don't know that, that's a database. You should know that. That just comes off. Gilbert's is unconjugated, so we have to keep that on there. PCPD is a hemolytic, unconjugated. Hypothyroidism can be unconjugated, so we'll keep it there. And physiologic. Wonder if even the answer had been breast milk jaundice. Let's say that had been down there too. All right, so let's come back. You can get, the problem with this question, I fear of those of you who missed it, why you missed it, you can tell me I'm wrong, but I can see how you might have read this question with contributing, using that word contributing. And so what you're sitting there thinking, well, you know, maybe there's a little physiologic, oh, there's a little breast milk. And so if breast milk had been down there as a contributing, then I can see where you would go. But let me counter. if breast milk had been there, not only because the timing isn't right, but this is, you go back to, why did they say colostrum? They're trying to say the breast milk isn't even in, hence that wouldn't have been the right answer. See, a breastfeeding, yes, right. Yes, breast milk, but breastfeeding. But why did they say colostrum? Okay, hold on. Okay, hold on. Let's say you tried to connect those dots, okay? That he was dehydrated, right? What would have been his hematocrit had he been dehydrated? Yes. Yes.
So if you're thinking about like now,
No.
my is like
65, yeah. I mean, newborn babies, look at the normal hematocrits of a full-term newborn baby. I mean, it's 58, 59, 56. I mean, that's clearly normal. So that's a way to look at that. And then you'd have to counter, if I'm going to make this be dehydrated, okay? He's had several meconium stools. That sounds like his gut's working. He's not. There is transition. I agree. I'm not saying that it would, but it's, that answer isn't down there, number one. But I'm just trying to use that, had it been, why that part of the question, say how you look at a question and take a part of it and say, why is that there? Okay. Why did they give you the hematocrit? So Rachel, if you want to go your way, I would say that's why they gave it. If you tried to play the dehydrated button, that doesn't fit a dehydrated baby because they would be hemoconcentrated. You see, I mean, this is how you. Yeah, well, if you don't know the normal values point, we'll take it. But I would.
Dr. Stallworth?
Yes, sir.
Can you repeat the questions if somebody that's physically present there asks something? Nobody else can hear them. Thank you.
I'm sorry. They're asking about, they were looking at this baby being dehydrated, and then they were connecting the dots of the cause of the hyperbilirubinemia in the face of dehydration. And so I was trying to say, well, if he was dehydrated, then he should have a hematocrit that's hemoconcentrated. And then their answer was, well, we don't know the normal hematocrit of a newborn. I said, well, not true. If you don't know that, you're in trouble. Does that do it, Scotty? Does that answer? Am I responding to your point?
Yes, sir. Nobody that isn't there can hear when they ask questions. So if you wouldn't mind when somebody asks it, just repeating it for everybody else.
I will do it. But that's the essence of what they were asking.
Yes, yep.
Okay. All right. So physiologic. Now, once again, Rachel, point well taken. Let's just say, because Rachel is the one who's interpreting it. Let me ask you this, Rachel. How did you answer the question? Okay, exactly. That's what I figured, but that's what I want. Okay. So let's look at physiologic. Now, this is where you look at this and you're trying to connect about 3 dots to make that be the right answer. And I'm saying don't do that. What they're trying to test you in is, when does physiologic jaundice classically come into play? Three to 5 days. How old is this baby? Hence not the right answer. Done. No. Don't try to look at me and roll your eyes. Not you. Done. Paige. I'm teasing you. No, you get my point. Do you get my point? Well, Dr. Gibson helped me there, because classic physiologic jaundice is 3 to 5 days of age. All things being equal. Yeah, I'll repeat it.
As early as 2 days, that first week is when you would see it. It does peak say 3 to 5. But Paige, you're exactly right. If you have a jaundice baby, that first 24 hours, it is never physiologic jaundice. That should come off the differential.
24 to 48, really. True. Okay, so Dr. Carney, Dr. Gibson just throwing in that the classic, anybody with, and look at the 14. It's not a 7, which would still be too high. So even 14 at 2 days of age, it's not physiologic. End of that story. Now, here's the trick, and this is where I was giving y'all credit back. could you say it had a contributing factor, like, and then I can see how you're answering the question. Does that make sense? Because I could say, well, you know.
I see where y'all come from. This is a tricky question because if you don't know about the crit, I could see where your argument is, well, we have a breastfeeding mom, so we're assuming breastfeeding jaundice, that plus physiologic could present with a bilirubin of 14. So I can kind of see.
Yeah, but you see, you're having to connect 3 or 4 dots to get to physiologic plus breastfeeding, you know, and then come back to why have they said it's an Asian? Oh, it doesn't mean, okay. Okay. So the team is saying they don't think Asian does anything for them because it's listed on the nomogram. Okay, I'll buy. But can you see that you're starting to construct so many things? Just not read the question, and just read the question for what it says and move forward accordingly. Does it, I mean, and so I read the question. Now, I had trouble with B and C. Okay? I mean, I did. I thought, now, wait a minute. Because I know that Gilbert's is one of those things that's, you know, causes early jaundice, just like hereditary spherocytosis. If that had been down there, that would have been a good answer. Yes, it is. But anyhow, so I looked at this and I said, okay, I said, why are they telling me it's Asian? With all due respect. Then it's a male, so I'm starting to say, and that hemoglobin might be a little low, or hematocrit might be a little low, so I put it together, and I have to say this has to be G6PD. Now, I can go back and tell you that if you look at jaundice in the first 24 to 48 hours, that's significant. The 14, G6PD pops up. It just pops right up. I mean, so this is not out there. I mean, it is right there, staring in your face, number one. And number two, to be 14, the Gilbert's would not be doing that. But see, I got caught with the word contributing because I was playing the game too. Well, maybe we have a little physiologic, maybe we have a little breast milk, you know, and so the contributing is the Gilbert's. But if you look at Gilbert's, they don't present the first days of life. It's too early. You've got an active process going on here. And the active process is they're deficient in G6PD. Okay?
I think one thing that might help with the Gilbert's is honestly, those are babies who are on phototherapy that aren't responding. So if they said you start phototherapy and the level, you know, does not improve, that might lean more for me towards a Gilbert or like a Kriegler-Najjar type 2 or something where they're not responding.
So Dr. Gibson's adding for the virtual audience that she would have loved to have seen placed on the phototherapy not improving, and then that would have pushed her a little bit more toward the Gilbert's or Kriegler-Najjar, etc. Okay? All right. Number 7, male infant. Well, there's a male, and again, we could ignore that, but they do say male. So, But the giveaway on this question is 1,500 ammonia. I mean, that is sky high. You know, that's not a fatty acid problem with a 1,500. That is a urea cycle defect. End of story. I mean, 1,500 male, 24 hours, you know, no, the glucose that's low. I mean, I don't know where else I can go. I mean, because it's the ammonia that's the problem. Okay. All right. Number 8. Again, this is referred back to the X-ray where you have to read the question. What is the diagnosis? Then you've realized the diagnosis is RDS, or, you know, premature baby, or hyaline membrane disease. And then you just have to know what is the chest X-ray. And again, we did our diffuse course infiltrates. We've already done that with some fluid in the fissures. It's transit to kidney of the newborn. Pleural effusion, that would have to be something like a chylothorax, something wild. And I'm not sure about the raised stomach silhouette. Other than that would mean air is showing it. Hence, I would go pneumomediastinum. So I'm back to what I said a while ago. And so the answer, just right off the bat, is a fine reticulogranular RDS, hyaline membrane disease, decreased volume. I don't know what else. That's just what it is. Number 9, 3-day-old bilious, keyword bilious, right? abdominal distension, okay? But he has passed stools. So they put that in there. So if you were trying to play the meconium-ileus or the Hirschsprungs, the fact that he passed meconium, and I know he could have and still had, but in a test question, take it off the plate. They put it in there. Why did they put it in there? So he's distended. This is a 3-day-old, and allergic reaction. That 3 days. Reflux. Well, what's the bilious vomiting all about? Hence, the answer is a midgut volume. Okay. Number 10. Okay. This is one a lot of y'all missed, and the key to this is the random nature. It's random. You got a left arm and a left hand and a right toe and so randomness, amniotic bands. Amniotic bands are random. I know that some of you looked at some other congenital anomalies. Please do not confuse rocker bottom feet with club feet. Those are two separate things. And the rocker bottom goes with trisomy 18. So that wouldn't be, it's not even on there. But once again, please, I would tell you, they're going to ask you arthrogryposis in some way, shape, or form. It's just, at least there'll be a question. They always ask something about arthrogryposis. So just read a little blurb on arthrogryposis, okay? Because they will talk about that. But the club feet, plus the other things, in this case, makes it be the amniotic bands, okay? Number 11, okay, 32-week, here we go with some bradycardia cyanosis, no respiratory effort, okay, so he's a preemie, everything, physical exam, head ultrasound, normal. In other words, they're trying to kind of tell you this is a normal baby, right? Right, when you see all these normal things and nothing abnormal, otherwise it's a normal baby. So that being said, why isn't hyperammonemia? What would have to be in the question for it to be hyperammonemia? What classic word goes with hyperammonemia? Vomiting. There's your classic connector. They vomit. Okay? So that's out. Quiet sleep, turning blue, I don't think so. Seizures, okay, but they're trying to say head ultrasound, electrolytes, things are normal. You just got to have a trouble with it being seizures. They didn't tell you the APGARs were 0 and 0. They just, so you're not led there. You're down to periodic breathing versus apnea of the premature. And when you look at all those descriptors of the cyanosis, right, bradycardia, this would be apnea of the premature, okay? Dr. Gibson, anything you want to say? Okay. Number 12, a lot of people miss this. Yes, I made this question up. Okay. Basically, you read the question. What are the two diagnoses that you always consider with delaying separation of the umbilical cord? LAD and CGD. LAD and CGD. LAD and CGD. It is just, that's the answer, okay? So then you have to go further and then say, what kind of organism of those listed go with one of those diagnoses? So this case is CGD, and remember it's your catalase-producing organism, so Serratia. Remember Serratia, if I'd had Aspergillus down there, if I'd had Staph aureus down there, you'd have been in trouble because I've done all of those, right? Would you agree? The Serratia is the classic giveaway for a CGD, okay? And none of those others fit that sort of thing, okay? 13, Prader-Willi, you just have to know the physical signs of Prader-Willi. Prader-Willi, uniperennial disomy, hypotonic, core feeder, failure to thrive, floppy, genitalia issues, small hands and feet, small hands and feet. All hands and feet. All those are classic Prader-Willi. So when they say except, and you see large feet, that's not small feet, right? So there's the answer, okay? 14, okay, a lot of y'all missed this one. And this is a tough question, okay? You should have gotten it down to 2, okay? So you've got, notice that they say the normal abdominal gas pattern. So did anyone in this room put diaphragmatic hernia? Okay, how did you take the diaphragmatic hernia with a normal abdominal gas pattern? How did you reconcile those two things? Oh, you didn't read the question. Okay. All right. Well, you do have to read the question. Okay. Do you see what I'm saying? I mean, that's the quick and dirty right there. But I can see when I saw left lower, because I thought, well, that's diaphragmatic hernia. And then you're going to say which one, and it's classically Bach-Dilleck. That's the most common, right? Because the Morgagni is in the midline, and a hiatal hernia is, I don't know that newborns have, I guess they do, but I don't ever see it. So your Morgagni is midline. This is not midline, but the Bach-Dilleck is left lower lobe. So that could be the answer. And then you've got cystic fibrosis, which doesn't fit at all. If you were caught between Bach-Dilleck and the cystic adenomatoid malformation, which is the only one left, what is missing in the stem of the question that would have pushed you toward the Bach-Dilleck? What is that classic pattern recognizer? Perfect. You should hear bowel sounds. They don't say that. Scaphoid abdomen. Remember? And that's not there. They don't have, it has normal gas pattern, and they don't talk about the abdomen being abnormal. So you're left with a localized multiple lucent areas being cysts. Hence the answer is cystic adenomatoid malformation. Okay, somebody's talking. Ashley Lynn's talking. I am Ashley Lynn, so I'm talking. All right, okay. All right, next is 15. A lot of y'all missed this one. Now, this is an NICU 24-hour obtunded seizures to Kipnick. A normal metabolic profile. In other words, he's not acidotic. So if you were doing urine organic acids, you'd be looking at a child with a metabolic acidosis. And they tell you he doesn't have that. So certainly this obtunded 24-hour is not galactosemia. That presents at 10 days to 2 weeks. Tox screen, okay. You could say, does the baby have some weird drug on board because mother took it? And I gotcha. Okay. But birth and delivery normal, the fact that they don't talk about the mother was a drug addict or the mother had no prenatal care, the mother just walked in. Why would you go there? There's just nothing that would push you to go there. And then long chain fatty acids, well, what would be there? Hypoglycemia. Fatty acid problem is hypoglycemia. They tell you the glucose is normal, so you're left with an ammonia. That's the right answer. You could look at the other one. Remember, what does hyperammonemia do initially? It's toxic to the brain and makes you breathe fast. So you have a respiratory alkalosis. Then, depending if you don't get on it, the baby goes downhill to a metabolic. Remember, it's like aspirin poisoning. Remember what happens when a baby takes the first dose of that? You have to know the steps. What happens first? They start breathing fast. They get a respiratory alkalosis before they get to the metabolic acidosis. Okay? But hyperammonemia, acute hyperammonemia will start to, because it's making the brain, it's toxic to the brain, and the brain, the reticular activating system revs up, and you start breathing fast, and your heart rate, and all that other stuff. Okay. They love hyperammonemia. So metabolic disorders, hyperammonemia, okay? But they love galactosemia. But that's at 10 days, right? Okay. 16, here's your arthrogryposis again. You just kind of have to know that. Most of you got this. This is not one that a lot of you missed. 17, the giveaway, if nothing else, is the oligohydramnios. So if you did not look at that word, because that that's classic kidney. Now, if you want to read it more, you should be able to figure out that this whole thing is Potter's. right? Which is renal agenesis, okay? But this is, I mean, the giveaway is the oligo, and you just move on from there if you didn't know, okay? But most of you got that. This was not this question. 18's okay. Back to the X-ray again. This is meconium. Meconium is coarse, filtrates bilaterally, increased lung volume, not decreased. Pleural effusion, no. Reticular granular, we've done. The mediastinal shift is a little bit problematic for me, depending on, you know, could a bigger yuck of meconium go down one side and kind of started creating a tension pneumothorax, if you will. So I don't know, Dr. Gibson, any comment, but I think the classic is the coarse infiltrate.
Yeah, I think it was just most likely.
Yeah, most likely, probably is, Dr. Gibson says. Okay, number 19. Now, a lot of you missed this one. So third years, I'll repeat. Who missed this? Number 19 about the 800 gram who got surfactant. This is just you know the side effect of surfactant. Who missed this? Third years all got it? Okay, Miss. Okay, talk to me about that. Tell me, Christina, I'm going to repeat what Christina says. She missed it. She thought it was an increase in intraventricular hemorrhage. Okay. All right. IVH again was the answer. Dalton, did you put IVH? Pneumothorax. Yeah. Okay. I think if you went up and just looked at the main side, I mean, remember the surfactant is irritating to the alveoli, you know, and I don't know, I've just always known it was, you always had to watch for pulmonary hemorrhage with surfactant. I hear what y'all are saying. You're not wrong, I bet, in the overall gamish of things to tell me that they are probably at an increased risk of IVH just because they're at 800 grammer. But that's not the question. The question is the surfactant. You see what I'm saying? So you have to read the question. Dr. Gibson, anything you want to say? Okay. All right, number 20. All right, now this is a good question. So you got an infant of a diabetic mother, right? So the answer is going to be E. Why so? Remember, there's this high glucose that mother carries all the time. The glucose causes the placenta, not the insulin. The glucose. So this baby is in a constant high glucose world. So the baby puts out insulin to maintain its normal glucose as mother is getting insulin because she's a diabetic. Then when the baby's born, here's this high insulin level the baby is used to. All of a sudden, the maternal glucose is cut off, hence the baby's glucose drops. So the answer is increased pancreatic insulin secretion of the baby, the babies. Does that make sense? Who missed that here? Does that make sense now? Did you understand? That's a physiology question you got to have clarity about, okay? All right. 21, emergency C-section. You know, the most frequent complication, perinatal asphyxia. I mean, that's just a straightforward question. Either you know it or you don't. It's kidney failure. Remember how sensitive those little tubules are? Those tubules, renal failure. Okay, well, it's renal failure. Sorry. Sorry. Okay, that was a miss. I'm sorry. Change that. That should be renal failure because that's the most common, because those tubules, you know, are so problematic with the kidney failure. So I just got typed wrong. Beg your pardon. Okay. All right. So we can, and again, we're not keeping these on a test matter. So it's renal failure. Okay. 22. All right. Remember how sensitive the renal, those little tubules in the kidneys, they're so sensitive to the need for perfusion, perfusion and oxygenation. You just get a ATN. Yes, yes. But now, hold on a minute. Let's come back. I'm not saying they can't have neck. I'm not saying they can't. I don't think that's a bad answer. Yes, yes. That's correct. That's correct. That's exactly correct. Or, I don't know, do we know what causes neck? Has that been determined? I frankly don't. I mean, it was never determined. Oh, it is? Okay. I'll bite on that. I mean, in my day, we never knew what caused it. The babies would get it, and we, you know, early feeding or whatnot. Okay, all right. Next, I think most people got is the classic neck, which is intramural air, right? Not that the other stuff couldn't be there, some of it, but it's the most specific for neck. 23, not past meconium, so you're in one of your two biggies. But of course, the others would be, we're at 48 hours. Well, if you had jejunal or duodenal atresia, you know, that wouldn't have never made it that far. They tell you that there's a normal appearing perineum, so anorectal malformation, that's out, and annular pancreas. Okay, okay. You could have some bilious vomiting with an annular pancreas. Okay, but the not past meconium pushes you into it being Hirschsprung's. So if you, did anyone answer annular pancreas here? Because that would have been the other answer I would have toyed with a second. Do what? Oh, I'm sorry, Dalton is saying stuff, but he won't let me repeat it for y'all in the virtual audience, so I'm not repeating it. It would be bilious vomiting. What else can I tell you? That's why that's not a bad answer, but it's the no meconium of the most likely. You connect those two dots and it would be Hirschsprung's. And the abdomen is distended. See, an annular pancreas, you wouldn't have a distended abdomen. Mm-mm. All right, the group was asking about how a annular pancreas would present relative to the answer to the question. So hopefully I answered that for the audience. Okay, 24. This is a 1-week-old vomited green material. Bilious, vomiting, always pathologic, right? So you're not just going to change the protein or treat it with ranitidine, correct? I mean, there's something bad here. Bilious vomiting would classically, of the two things you see, point, and it just says abdomen is soft and only mildly, as opposed to the previous question where it said abdominal distension. So the logic is this would be an upper GI abnormality. So the barium enema wouldn't help you. Okay, so you're kind of down to an abdominal ultrasound versus an emergency upper GI. Now, who missed this question? All right, so Liz, tell me, I'm gonna repeat what Liz said. Liz, did you put emergency ultrasound? Yes. Who else missed it? Did you put emergency? Okay, that's what I figured. All right, so tell us your thought process. Everyone who missed it, put emergency ultrasound. Tell me your thought process. Okay. All right, stop. I totally understand and I totally agree. When does a kid with pyloric stenosis present? On a test question. What's the classic age of presentation of pyloric stenosis? 4 to 6 weeks. 4 to 6 weeks, number one, and this is a 1-week-old. Number two, is it bilious vomiting or non-bilious? Non-bilious. It's pre-pyloric. The bile can't get there. So how did you reconcile the green material to make it be pyloric stenosis to let you get the answer of an ultrasound? Yeah, you see, and that's fine. I'm not criticizing you. I'm trying to teach, see, because that's really why that's the wrong answer. Okay? Okay, all right.
If you're like somewhere where they can't get one, like one of the like you get this one doesn't not for answering the question purposes, but
Right.
just for like
Well, yeah, an ultrasound would help you with a big liver. No. Mm-mm. The ultrasound is not going to do that for you.
so if, like,
It might help you with an intussusception, might. It would help you in the right hands with pyloric stenosis. It would help you with organomegaly. But when you're looking at abdominal pathology relative to kinks and stuff, ultrasound is not where you're going.
so like if a kid's coming with bilious vomiting, well, is there anything you do to save
Yeah, what would you do? What would you do?
Put an NG tube in.
Okay, you could put an entry tube down, that's great. But for diagnosis, what would you do? What is about, remember your things like double bubble, and you do a routine film, and you'd look at the gas pattern, and you'd say, this is obstruction.
That would be your next step if you can't.
Yeah, if you couldn't do it, yeah. That's what I would do. And then you realize it's obstruction, and an obstruction is an emergency. And so that's what I would do. See, and an ultrasound doesn't do that. It doesn't, you don't get an ultrasound for obstruction. You get an ultrasound for anatomy. Now, I'm not saying that an obstruction can't alter the anatomy, hence an ultrasound can't be gotten. But you see the basics of what I'm trying to say? In the general world. Now, you could get me a highfalutin ultrasonographer, you know, and I'm sure maybe they could tease out the difference. But remember, this is not an X-ray test. This is a GenPEDS test. Okay? All right. How are we on time? Okay. 25. Seemingly healthy, fed formula, no emesis, big deal. Flat plate, large dilated, okay, absence of air, the rectosigmoid. There you go. That's, Dalton, you kind of led me into this. So you don't have any air lower, right? And you've got dilated loops. What are you in? What are you in? What general category? Obstruction, okay? But there's been no vomiting. Where do you think the obstruction might be? Lower or upper? Lower. And it's validated by the fact that there's no air in the rectosigmoid, and the rectosigmoid is lower. Would you agree? So if nothing else, the pathology is lower. Well, fluoroscopy, swallowing study, upper. Meckel scan, kind of upper. Ultrasonography of the gastric outlet, ergo pyloric upper. Upper GI series, upper. There's only one that's lower. I mean, if you didn't know anything else, you could just look at that from that standpoint. Hence, the right answer is A. Okay, and let me look back. Oh, 1 second. No, man, a lot of y'all got that. Okay. 26. You always test babies' hearing when they're asleep, right? Okay. All right. 27. This is either you know it or you don't. You just got to take your physical exam things down and you look at it. And so you've got coloboma, you've got a heart defect, you've got unable to pass a French, in other words, atretic nares. Let's see. They don't talk about the weight of the patient. Okay. You've got genital abnormality, cryptorchidism. You've got an ear abnormality, abnormal ears. I mean, what do the letters stand for? Charge. Coloboma, coloboma, heart, atretic nose, nose atretic, there's the A, and R, I think it's A, is it AR? What's the R? Yeah, AR, okay. The R is growth retardation. That's the CHARG, retardative growth, if you will. And genitalia is the G, and then the ear abnormality is the E, and that's the charge. Now, the renal coloboma syndrome, because he does have coloboma, and he does have an ear abnormality, but that's all you have. You don't have that other stuff. DeGeorge, you shouldn't have gone through. That's A. Brachio-odiorenal, okay. All right, you've got, it's ears and kidney and pitch, the brachial clefts in your, so where's our heart coming from? And then the bacterial, and it's always confusing on charge versus bacterial. But remember the bacterial, just remember the V and the TE. You got vertebral, tracheoesophageal, you do have cardiac, you do have kidney, and then your limb abnormalities. Remember, that's kind of bacterial. Yes, Megan. On the physical exam, left-sided facial droop. Well, it's there. You mean, does it go with charge syndrome? Yeah, I don't know if that, do you know? I'd have to look that up. I don't know. They may have an increased instance of I'm trying to play the game of a peripheral nerve, facial nerve palsy, but I'm not sure I know how that feeds into that, to be honest with you. Maybe somebody that's part, they say it's part, Ashley says it's part of the ear abnormality, the facial nerve. Yeah, that's what, that's where I'd have to go. That's what, thank you, Ashley. Okay, 28. Well, this is an ethical question. And Megan, it's very straightforward here, right? It's looking at the age of this baby at 23 to 7. It's 20 to 22 weeks versus 22 to 24 weeks versus greater than 24 weeks, right? So, it falls right into parental request, okay, for that classic. If it's below that, you do nothing. If it's above that, you do everything. And when you fall into that classic age, it's parental request. 22 to 24 versus greater than 20 to 22, excuse me. Or what is it? Is it 22 to 24, less than, and less than 22? Less than 22 to nothing. Yeah, exactly. Okay. All right. 29. Ooh. I love this question. I will admit that. Now, this is a tough question. This is, in my mind, a lot of the stuff we've given, and I'm not putting you down if you missed it, because the point is to learn it, but a lot of it is pattern recognition, just database, or putting it. This one requires a lot of thinking, okay? This is tough, all right? So let's try to break it down. So number one, look at this, and they see, you've got to know the thyroid ultrasound reveals a normal sized gland. So the baby has a gland. The baby does not have a hypoplastic gland. The baby does not have an atretic gland or an absent gland. So this is not primary hypothyroidism because he doesn't have a gland, okay? That's what that sentence tells you. Yet when you look at the labs, he's got a low T4 and a high TSH, he's hypothyroid. Now, in medicine how we always play the game. All the things could be there, but if they have a receptor that doesn't respond, it's just like whatever's there isn't there. Since they tell you it's there, then you're stuck with it's not responding. And then you have to say, well, why wouldn't a receptor respond? Well, which disease has antibodies blocking the receptor? Graves' disease. Hence those antibodies of mother's Graves' disease. Now, I know she's had her thyroid taken out. She still has antibodies. This is not acting on her thyroid. Are crossing over, blocking the baby's thyroid gland. So therefore the thyroid ain't working. Therefore the TSH is going up. The T4 is low. See how this works? Now, you can say, well, Dr. Stallworth, the Hashimoto's has antibodies. Correct. Do they have receptor blocking antibodies? No. That's the Graves' disease. So I kind of wrote all this out to say, and I'll try to read because I was trying to go fast. So the baby has a gland, but it's not taking up the technetium because the antibodies from the mother are blocking such. So the baby has the response by increasing his TSH. Thus, it looks like the baby has thyroid agenesis, for example, but the ultrasound is normal. In other words, he doesn't have thyroid agenesis, okay? Now, you could say, well, maybe the baby has panhypopit. Dalton, why would you look at this question and say to me, no, the baby doesn't have panhypopit? That's not an answer, but let's just pretend like it was down there. Dalton, for the group, is thinking. Think through this, Dalton. See, this requires you to really think and understand physiology. Perfect. What? Yeah. If he had panhypopit, he wouldn't be making sense. His THS would be low. And then if that answer were down there, that'd be the answer. You see, because he's not making TSH. And so the mother's thyroid stuff would have been a big bunch of, I mean, and they wouldn't have been fair to do that to you, but I'm trying to get you to understand the physiology of what's going on. Is this clear to y'all? Do you follow what I just said? You understand how that works? Yeah, Liz. Okay. Okay, well, if baby's thyroid was suppressed because he had plenty of thyroid, why would the TSH be elevated? There's your answer. You see? So if the baby just had a whole bunch of people, you do. That's true.
No, you wouldn't. So the big thing
So,
is this.
which for the group, Dr. Gibson, I will repeat, is answering Liz's questions about the post-birth thyroid surge.
Right. So one of the reasons we repeat the thyroid studies on newborns for moms who have levothyroxine unborn during pregnancy is because you could mask a congenital hypothyroid. The reason for that is on the newborn screen for these babies who are exposed to Synthroid, they're going to have a normal TSH. You're not going to have that surge. You're basically having a pre-treated congenital hypothyroid on your DHEX. The TSH is going to be normal, either because the baby's fine or in response to mom's levothyroxine that the baby saw. That thyroid surge I would not expect to persist at day 6. And so what it sounds like you're asking is, since we're repeating it, it should have normalized. So if the question was, I don't even know how to make it work with the 100, because the 100 is a really high level for the TSH on the baby. And I'm not an endocrinologist, so I don't know how high it possibly could go clinically. Usually if we have a TSH on the DHEC that's 40 or more, we actually start treatment. So 100's really up there. But does that help at all?
Okay, so Dr. Gibson's essentially saying that the thyroid surge at 6 days of age for us to have what's before us from the labs would not fit that being what's going on, even though this mother had been receiving thyroid supplementation. Okay, so we got about 4 minutes, so 2 questions. The last one, Ashley, did you get this answer correct? Oh, Ashley, no, Ashley knows who I'm talking about. Oh, good for you. Well, I taught yesterday on rounds, and so here's a baby, 10 days, vomiting, hypothermia, you know, dipstick for glucose is negative, but that has reducing substance. What's reducing substance? Monosaccharide that reduces Benedict solution, right? Which is our non-reducing sugar, which is the only non-reducing sugar. Because you take the 2 monosaccharides and hook them end to end so they don't have the reducing end. Because, you know, sugars are, you know, like trains when you have the caboose, but if you take the caboose and hook it to the engine, then you don't have a free end. Okay, well, that's sucrose. Remember, sucrose is a disaccharide of glucose and fructose, and they're hooked end to end, so that is your non-reducing sugar, sucrose. All the other sugars are reducing, okay? Hence, you have this, in this case, with this baby at this age and vomiting, it's galactosemia. But of course, that's not the question. You have to go further and say, what bug are you set up for with galactosemia? And the answer is E. coli. Okay. And our final question, yes, I made this one up. You're going to kill me. But I did this for a good reason, that I realize this is a tough question. You don't know it, but let me show you how you could put it together. Okay. So you got a single mother, no prenatal care. She has a baby that's dysmorphic. Now, the real trick here is read the dysmorphisms and tell me what the syndrome is. So if you don't know the syndrome, you're out of luck, right? Okay, but if you have microtia, you have facial bones, you've got craniofacial abnormality, coloboma of the eyelids, you should know this syndrome. We talk about this, I talk about this syndrome all the time. What syndrome is this? Treacher-Collins. So this is Treacher-Collins syndrome, okay? Now, look at, what do you think the TC stands for in the mutation? Treacher-Collins. So sometimes before you just give up, read that, and if you can think, well, this sounds like, and you see TC, then you still not good enough to get the answer, correct? But at least you're making some headway. And then you have to know, even though there are many different permutations, what's the classic way that Treacher-Collins is inherited? Autosomal dominant. It's autosomal dominant. So the answer is autosomal dominant. That's your classic answer. Now you can read about Treacher-Collins and there's some recessive in there, but with this mutation, it's autosomal dominant. So if you want to try to, push back, I'll bite, except that's why I put the TCOF1, because that's autosomal dominant. Because a single mother, because the trick is, if it's autosomal dominant, why didn't I put the father had it? So I didn't want to do that, because you would have said, well, you should have said something about the father, rightfully so. And I said she was single, so that you didn't know who the father was. So you couldn't look at me and say, well, you didn't say the father didn't have his autosomal dominant. The mother doesn't have it. I didn't say that, but the father did. So that's why I put a single mother. Maybe I should have put a mother who didn't know who the father was. Would that have been better? Okay. Maybe that would have been more politically correct. But you see what I was trying to do. Yes, I made this question up myself, Liz. All right, people. 1:15. Bye. Thank you, Dr. Gibson. All right, thank y'all. What is it?
I would like to see your questions. Like, oh, he loved this.
Well, it just happened randomly. I thought about it because they presented hyperbiliary yesterday.
Oh,
So
cool.
of course I had to go there.
Yeah.
And I said, if y'all miss this, I said, who's taking this test? And Ashley had. So I was happy she learned.
Well, it was funny because the other day, the Ashley and Newborn with me was talking to me about the hypothyroid.